thank you very much, and I'm not sure my team is that bad, but we'll see. We still have a couple of more weeks left. But more importantly, I'm here today to talk a little bit about a project that we're working on. I think most of you know about insulin and the role of insulin and its importance in glucose uptake. And I'm going to try to talk to you a little bit and convince you that insulin also is an important mediator of the sympathetic nervous system in humans. So just an overview of the presentation. I'll talk about the sympathetic nervous system, talk a little bit about sympathetic overactivity when that system becomes dysregulated and how that impacts health and how that might be related to insulin resistance. Then I'll focus primarily on insulin-mediated sympathoexcitation and give you an understanding of the interaction, because insulin can also have direct effects on the vasculature and how they might be balancing one another to regulate your blood pressure. And then I'm going to present two studies that we've recently performed to better understand how insulin is regulating the sympathetic nervous system. The first is looking at insulin sensitivity on insulin-mediated sympathoexcitation with an influence of endurance training and how that might be impacting the ability of insulin to regulate not only glucose uptake, but also the sympathetic nervous system. And then the second is an influence of insulin on the arteriobaroreflex control of sympathetic outflow and how important that might be in regulating the sympathetic nervous system after a meal intake. And then I'll end with a summary. So to start with, just as an overview of the sympathetic nervous system, you have afferents that feed into the central nervous system, arterial chemoreceptors sensitive to oxygen and carbon dioxide, arterial baroreceptors, very important in the beat-to-beat regulation of arterial blood pressure, cardiopulmonary receptors, which sense pressure and volume in the heart and lungs, skeletal muscle afferents, which are comprised of mechanical and metabolic afferents that reflexively stimulate the sympathetics, particularly during exercise, and then circulating factors. So all of these afferents can impinge upon the central nervous system and influence its outflow, or the efferent side. And that outflow can affect a variety of organs, being the heart, the viscera with the kidney, splanchnic area, as well as skeletal muscle. And importantly, in skeletal muscle, plays an important role in your regulation of arterial blood pressure. And overall, when most people think about the sympathetic nervous system, they think about how important it is in the regulation of blood pressure. And I believe it is important for the regulation of blood pressure. However, the sympathetic nervous system also plays a variety of other roles, as noted by the variety of organs that it can affect. And in that regard, when you have sympathetic overactivity, these other roles become very apparent in what might happen with the sympathetic nervous system and the other functions that are independent of blood pressure regulation. And I'll put those here on this slide, where we're looking now at the sympathetic efferents and what might go wrong when you have sympathetic overactivity. Well, for the heart, you can develop cardiac hypertrophy. Again, that can be independent of blood pressure. I can go through those, but that would be a whole talk in and of itself. But the important thing to remember here is there are a variety of things that the sympathetic nervous system that can do that are independent of blood pressure. And then it also can cause arrhythmias and sudden cardiac death. For the kidney, excessive renin release, renal vascular resistance, alterations in sodium reabsorption, as well as glomerular sclerosis. Then in the periphery, you can have excessive peripheral vascular resistance as well as vascular hypertrophy. So this is very common. These are very well-known deleterious consequences of sympathetic overactivity. And the reason this is important is because there are a number of diseases that I'll show you on the next slide that have sympathetic overactivity, yet we're not sure what the underlying mechanism is. And those diseases are listed here. So hypertension, heart failure, kidney disease, being overweight or obese, metabolic syndrome, and a variety of others. And the point I'll make is that obviously it's an excessive list, and yet we know they have sympathetic overactivity. We're not quite sure what the underlying mechanism is. Well, one thing about these diseases is they also tend to be associated with metabolic disorders. And a primary metabolic disorder associated with some of these diseases is insulin resistance. And so that's kind of the theme of the talk today. And I want to know whether there's a link between this, where insulin resistance and sympathetic overactivity are occurring together in a number of diseases. Well, does that mean that insulin and sympathetic nervous system are tightly linked? And so that's the question. Is insulin the link between disturbances in both the sympathetic and the metabolic systems? So that, as I said in the beginning, there's been a number of studies examining insulin and its metabolic functions. Today, I'm going to only focus on sympathetics and how insulin might be regulating the sympathetic nervous system. I'm not going to talk at all about the metabolic actions of insulin. So to start with, I'll show you this original data in 1991 by Anderson et al. And so you can get acquainted with this slide. This is a neurogram of muscle sympathetic nerve outflow. And each one of these bursts, each one of these upward swings represent a burst of sympathetic outflow. And that's derived here. If you're unfamiliar with how this is done in humans, it's done with the technique of microneurography, where basically in the peroneal nerve we can insert an electrode, and by moving that electrode around, obtain a direct recording of sympathetic outflow to the blood vessels. And so that's what was done here, and this is under a control condition. So this is a baseline or resting level of sympathetic outflow. Again, each of these upward deflections represent sympathetic nerve activity. This is a quantifiable way to look at the nerve. It's 220 in this case, and basically they just take a culmination of the burst height and the number of bursts. So just remember the number, the higher the number, the more the nerve activity. The lower the number, the less the nerve activity. And then there's blood glucose and plasma insulin. And what I'm showing you here, that's just baseline. And now I'm going to show you the nerve after insulin was infused while maintaining blood sugar. And I think what you can do is, and what you can appreciate from this, is the number of spikes after insulin was infused is much greater than before. And if you're a numbers person, we can just look at the numbers. It goes from 220 to 684. So that's a pretty large increase in sympathetic nerve activity by infusing insulin and keeping blood sugar constant. It went from 90 to 98. That's not much of a difference. So basically, for all intents and purposes, blood sugar was held constant, and insulin was about 7-fold higher. So a very large increase in insulin causes a very large increase in sympathetic outflow. And this is in healthy humans. There's also been some animal work done, and I'll show you that here. Again, this is the hyperinsulinemic euglycemic clamp. So they're infusing insulin and maintaining blood sugar. And basically, they measured 3 different nerves: the adrenal nerve, renal sympathetic nerve activity, as well as lumbar sympathetic nerve activity. That muscle sympathetic nerve activity that I showed you on the previous slide in the healthy humans is similar to lumbar sympathetic nerve activity in the animal models. And I'll just show you what happens there in control, and low-dose insulin and high-dose insulin. And you can appreciate that this level of lumbar sympathetic nerve activity is lower than the insulin at the low dose. It increases a little bit, and then at the next dose it increases a little bit more. So it looks like a dose-dependent increase in sympathetic outflow that's mediated by insulin. Now, insulin is given systemically. So one of the things you can do in animal models that we cannot do in our humans is we can directly give insulin into the brain. And so I'll show you that data next, and that's to differentiate whether there's a central effect of insulin or is it working through some peripheral mechanism. If you give it systemically, you can't differentiate the two. But now in an animal model, if I compare what's done when I give it systemically to what's done when I give it directly into the brain area or the central nervous system, then I can differentiate the two. And that's shown here. This is time on your x-axis, and then the change in lumbar sympathetic nerve activity on your y-axis. And basically what they've done here is given insulin intracerebroventricular, so directly into the central nervous system. And you can see, compared to the vehicle infusion, there's again a dose-dependent increase. Low dose, get a nice increase, and high dose, you get a little bit more in sympathetic outflow to the lumbar region with insulin. So what this says, and what it allows you to understand a little bit, is it appears that insulin is increasing sympathetic nerve activity through a central effect, not a peripheral effect. And remember the slide I showed you initially, there are a lot of afferents that come from the periphery that might be modulating this. So I think this is an important point to understand, that it's a direct effect on the central nervous system. So in order for us to understand how insulin is working, I need to provide you a little understanding about the insulin receptor and insulin signaling. So what I'm going to do is I'm not going to go through all of this. I'm just going to simplify it for our purposes of what we need to know to present some of the data that has tried to understand how insulin is regulating central sympathetic nerve activity. And so basically insulin can bind to its receptor. And we want to know, okay, if it is, what is causing the increase in sympathetic outflow? And all I need you to remember from this slide is there are two main pathways in which the insulin receptor works and insulin signaling works. And that is this pathway right here, which is PI3K, or phosphatidylinositol 3 kinase. That's one pathway. So if you remember that, you'll be good. The other is right here, MAPK, or mitogen activated protein kinase. And that's the other pathway. And basically what's been known about this, these are the two primary pathways for insulin signaling. This side is more non-metabolic, and this side is more metabolic. And now I want to know, and others want to know, if insulin is increasing sympathetic outflow, how is it doing it through the insulin signaling pathway or the insulin receptor, through PI3K or through MAPK? And I'll show you some data from Ramuni et al. On this slide. And so they did the same thing I showed you before, where they gave intracerebral ventricular insulin, and they had three conditions. Again, this is lumbar nerve activity, basically the change in SNA after vehicle, which is in the white, plus insulin. So that's basically just giving insulin. And as I showed you before, you get a nice increase in sympathetic outflow. And then they gave LY294002, which basically all you need to know about that is it's a PI3K inhibitor. And when they did that, they got a slight reduction. They also gave Wortmannin, which is also a PI3K inhibitor, and they clearly get a reduction there. So in essence, by blocking the PI3K pathway of the insulin receptor, they are minimizing or almost obviating the increase in sympathetic outflow by giving insulin. Well, what happened with the other pathway, MAP kinase? Does it work through that pathway as well, or is it specific to PI3K? And that's here. And as you can appreciate, again, lumbar nerve activity, this is the vehicle plus insulin, so insulin alone, get a similar increase as before, as you would expect. And now, if they use these are two known MAPK inhibitors. And when they gave either one of those, there was basically no change in the increase in sympathetic nerve activity evoked by insulin. So indicating that the MAPK is not really playing a role in insulin-mediated sympathoexcitation, and it's through PI3K. That's important because I'll come back to this slide, and if we follow PI3K, and if that's responsible for lumbar sympathetic nerve activity, let's take this path a little bit further down. I think a lot of you are probably familiar with nitric oxide synthase and nitric oxide production and vascular, that's a potent vasodilator for vascular relaxation. We'll take a look. The same pathway that increases sympathetic outflow also increases vascular relaxation. Why would that be? Well, when you give insulin, you need vasodilation in skeletal muscle because remember, what's insulin's primary job? Glucose uptake. Most of your glucose is disposed in skeletal muscle. That's where most of the uptake is taking place. And therefore, you need to have dilation to get more blood flow with more glucose. Well, if you let this go and just have a complete dilation in your periphery, what do you think is going to happen to your blood pressure? It's probably going to plummet because you're causing a massive vasodilation. So if at the same time, insulin can increase sympathetic nerve activity and restrain some of that dilation, it will help to maintain arterial blood pressure. And that's a primary function of insulin in regulating the sympathetic nervous system, is allowing for the control of your blood pressure. And I'm going to show you an example of that on the next slide. So this is just showing you a control subject here. This is mean blood pressure. There are 2 dots here indicating their baseline resting blood pressure. The important thing is this side here. This is a sympathectomized patient. Before they had real good therapies for treating hypertension, one of the ways which you treat hypertension was a sympathectomy. So this is older data. It was reported in 1981, and I think before, probably in the 1970s, is when they were doing a lot of these types of maneuvers to alleviate hypertension before we had the pharmacology that we have now. And the bottom line is here, this patient no longer has the sympathetic nervous system to counteract any effects of insulin or mediate the insulin effect. And what happens after they eat a meal? Well, basically, the control subject has no change in blood pressure, okay, which is what you would expect. I don't think any of you pass out after you eat, so therefore your system is working very well. And it's likely the balance between the dilation and the sympathetics that allow for that. In this patient who had their sympathetic nervous system removed, if you will, and non-operational, well, you still get insulin-mediated dilation, but you get no counteraction. Insulin cannot increase sympathetic nerve activity. It's not there. And what happens? Their blood pressure plummets. So that's the idea of insulin, at least in a very simplified manner, is it helps to balance the dilation needed for glucose uptake with the ability to regulate your blood pressure and maintain your blood pressure. So let me give you a little summary so far. In addition to the well-described metabolic actions of insulin, I've shown you that insulin can increase sympathetic nerve activity. It appears to be a central effect. And it seems to be working through the PI3K pathway. And basically that sympathoexcitation we think would serve to balance the vasodilation and maintain your blood pressure. So if you're more of a picture person, we'll show you insulin through the central nervous system, increasing sympathetic outflow. Very simple take-home message on that point. So now the next question we want to ask is, what happens if you have impairments in insulin signaling? So you're all probably very familiar with the metabolic syndrome or diabetes, the so-called insulin resistance. And so this is data from subjects who are obese versus subjects who are lean. The obese subjects have insulin resistance. And basically what they've done here is they do the hyperinsulinemic euglycemic clamp. So basically they're giving you insulin and they're holding your blood sugar constant. When you do these infusions, the amount of insulin you give is based on body weight. So that's why this obese group, which is in the squares, the open squares, they get much more insulin than the lean group. Again, it's giving insulin based on body weight. That's how these clamps are performed. So if you look at that, that's just indicating that now, when we do this clamp, the lean subjects get X amount, 400 of insulin, and the obese subjects are getting closer to 600. Well, we're just interested, okay, if you do this, what happens to sympathetic nerve activity? Because we know one of these groups is insulin resistant, the other group is insulin sensitive, or they're at least normal insulin sensitivity. Here's the sympathetic nerve activity. This is the change percent baseline in muscle sympathetic nerve activity over 120 minutes of the hyperinsulinemic euglycemic clamp. And I think you can appreciate that basically you get no change at all in the obese subjects, where you get a normal increase, like I showed you before, from the first part of the talk in the lean subjects. So they're capable of getting this insulin-mediated sympathoexcitation, whereas the subjects that are insulin resistant do not appear to get an increase in sympathetic nerve activity. This has also been shown in 2 other studies where they've used metabolic syndrome. Again, these are just obese insulin resistant. These are metabolic syndrome, which is kind of similar to obese insulin resistant with a couple of other markers as well. And then also been shown in insulin-resistant elderly subjects. And some elderly subjects actually they get postprandial hypotension. And so this becomes a real important follow-up, because basically you eat at least 3 times a day, if not 5 or 6. And if every time you eat, you're having an imbalance between the dilation and the sympathetic nervous system, you might have a dysregulation of your blood pressure and becoming more and more hypotensive episodes. So we wanted to ask a question in regards to the understanding that insulin resistance might affect the ability of insulin to increase sympathetic outflow. And our question was, does an insulin-sensitive state alter insulin-stimulated sympathoexcitation? So we're approaching it from a different standpoint, and one that I think all of you can appreciate in the department that you're in. And that is, we want to go after it from an exercise training standpoint. We well know that when someone is highly trained, they are highly insulin sensitive. It's one of the benefits of exercise training. And I'm just showing you that here. This is a glucose disposal rate. This is plasma insulin. The black line indicates a sedentary subject. The yellow indicates an endurance trained subject. And all this shows you is that in the sedentary subject, it takes much more plasma insulin. You're higher up on your x-axis for the same glucose disposal rate. Okay? So look at the yellow, less insulin for the same glucose disposal rate. That's insulin sensitivity. They don't need as much insulin to dispose of the same amount of glucose. So now, that's just glucose uptake. That's the metabolic side. We want to know whether or not this is working in the central nervous system. We know that insulin works through the central nervous system to increase sympathetic nerve activity. When someone changes insulin sensitivity, does that affect their sympathetic response to a given level of insulin? So this is the setup that we use to test this. Basically, we're measuring muscle sympathetic nerve activity, as I showed you in that original picture. IV blood draw, that's just we want to measure glucose and we want to measure insulin to know what those two are doing and what their levels are. ECG for heart rate and blood pressure. And what we did is we simply took subjects who were average fit, a VO2 peak of about 44 mLs per kg per minute. And we compared those to a high fit group. So these are the guys who are out running in rain, snow, whatever it is, they're out there running or cycling, and their VO2s are 66. Most of them are competitive triathletes or cyclists, a variety of different events. But the bottom line is they're training 2 to 3 hours a day. They're extremely high fit. So now we want to know if we give them a mixed meal, so we're increasing circulating plasma insulin, how is that going to affect the sympathetic response following the meal? And so basically we made these measurements at baseline and 120 minutes following the consumption of the meal. And our main focus, again, is on the sympathetic nerve activity. So just understanding how that's being affected by the change in insulin sensitivity. So first, we just show you the glucose level. Okay, so this is average fit in the black, and the high fit are in the gold. This is time on the x-axis, glucose on the y. And so after this is time 0 is when they ingested the meal. This is just like an ensured drink. And basically, as you would expect, glucose goes up. You just took in a bunch of calories. If you look at the two groups, the glucose goes up equally in the average fit and the high fit. And basically what I'm showing you down here is just area under the curve for glucose. Okay, so similar increases in glucose following a meal. Not surprising. The reason why I want to show you this is because I have to show you that the subjects that were high fit were indeed insulin sensitive. And this data shows you that. Here's the high fit subjects and the average fit subjects. So the high fit subjects over the 120 minutes had much less of an increase in insulin compared to the average fit subjects. Okay? And if you look at area under the curve, there's significantly less insulin released in the high fit subjects. That would make sense. I just showed you that diagram before. For the same glucose disposal rate, an endurance trained subject would need less insulin. They're more sensitive. So to help you interpret the SNA data, just put this in. So if in an insulin-sensitive state, if that alters insulin-stimulated sympathoexcitation, basically what we would say is despite that lower insulin concentration that I showed you, then the subjects who are high fit should exhibit either a similar or a greater increase in sympathetic outflow. Even though they have low insulin, they should be getting more sympathetic responses because they're more sensitive for a given level of insulin. So what did we find? This here is MSNA. Again, this is burst incidence. I think I won't go through all of the different ways you can present the data. Suffice to say, nerve can be interpreted a variety of ways, and this is the most valid. I could show you the other data as well afterwards. But over 120 minutes, basically here's your average fit in black, here's your high fit in gold. And you can appreciate that the high fit subjects had a greater increase in sympathetic outflow. If we just present the data as a delta from the baseline, there were no differences in baseline activity, but just to be sure, we present them as a delta, a change from time point 0, again, where you ingest the meal, you can clearly appreciate that the change in nerve is less in the average fit, or in other words, is much greater in the high fit subjects. So one caveat, I'm not going to mention more about it, but just blood pressure and heart rate changes following the meal were similar between groups. Okay, but the take home here is that the high fit subjects got much greater increases in sympathetic nerve activity following the mixed meal. And if we present the data as a ratio, the delta MSNA over the delta plasma insulin, you can appreciate the average fit are in black and the high fit are in gold. And if you do this, basically for a given amount of insulin, the high fit subjects are getting much greater increases in sympathetic outflow, i.e. it looks like they're more insulin sensitive or there's a greater central insulin sensitivity. So as a summary, high fit subjects exhibited lower insulin area under the curve, similar glucose concentrations. That's just the foundation. I just needed to show you that they were indeed more insulin sensitive. That's very well known. We just wanted to document it. The more important thing is the increase in MSNA was greater following meal ingestion in the high fit subjects. And when you express it in relation to plasma insulin, there's a much greater sympathetic outflow for a given amount of insulin in high fit endurance trained athletes. Okay, so again, I started with the insulin can increase sympathetic outflow. I now show you that insulin sensitivity can modulate the ability of insulin to increase sympathetic outflow. And then the last part of the talk will basically focus on the arteriobaroreflex control of sympathetic outflow and how insulin might modulate arteriobaroreflex control. Okay, and this data is basically following up on information we've learned from some animal studies, and I'll present that data right here for you. Basically, if you're unfamiliar with the baroreflex, this is a baroreflex function curve. Mean arterial pressure is on your x-axis. The change in lumbar sympathetic nerve activity is in your y-axis. Baseline is this solid line. Basically, you start here and you give drugs that raise pressure and drugs that lower pressure, and you measure the sympathetic outflow. If you raise pressure, you'll lower sympathetic outflow. If you lower pressure, you'll raise sympathetic outflow. That's pretty much what you need to know in regards to this figure. And what they've done is they've given insulin, again, through the intracerebral ventricular. This is directly into the lateral ventricle. And in essence, they follow this at 30, 90, and 120 with a arterial baroreflex function curve. And you might not be able to see it on here, but the bottom line is, as you go from baseline to 30 to 90 to 120, there's an increase in the slope of that line. And really what you need to know for that, that means that the baroreflex is working better. It looks like insulin can increase baroreflex sensitivity. And just if you watch the figure, you can watch these might help you. There's the slope at the slope of that relationship at rest, and then you can see it becoming steeper as you go from 30, 90 to 120. So in essence, if you look at summary data from this study, this is the gain or the sensitivity of the baroreflex, which is the slope of this line. The steeper the slope, the more sensitive the baroreflex. And then basically this is at control, 30 minutes, 90 minutes, and 120. And you could see that the gain is increased. So in understanding that as a background, we wanted to know, can we translate these findings in rats to humans? Does insulin influence arterial baroreflex control of sympathetic outflow in humans? And basically the similar setup to before. We measure muscle sympathetic nerve activity. We need a beat-to-beat blood pressure for this since we're doing the baroreflex, and that's done by a phenopress where we can measure at the finger continuous blood pressure. We have IV for blood draws, ECG, and a brachial blood pressure just like before. This is in a group of healthy young subjects. We gave a mixed meal, and then we followed that by making measurements of arterial baroreflex control of sympathetic outflow. And I'll show you how we did that on the next slide. So basically you can collect a baseline resting period of sympathetic outflow, and you can relate the nerve activity to blood pressure, and you can derive a slope from that. Again, the slope being an index of the baroreflex. The steeper the slope, the greater the baroreflex sensitivity. And that's what this is showing you. This is diastolic blood pressure, MSNA burst incidence. The slope of this line indicates baroreflex sensitivity. That's at baseline. Let me show you what happened at 120 minutes of the mixed meal. I think you can appreciate that this slope of this line is shallower and this one is steeper. That indicates that the gain or the sensitivity of the baroreflex was increased following the mixed meal. Summary data is presented here. This is MSNA burst incidence. Again, the gain or sensitivity of the baroreflex. This is at 0 before they ingested the meal, and this is at 30, 60, 90, and 120 following the meal. And you could see at all those time points there was a significant increase in baroreflex sensitivity. I need to show you the insulin because one of the points I made before is that after you eat a meal, obviously insulin's going to go up. I showed you that initially. But what's the other caveat? Glucose also goes up. So really we don't know, is that effect directly due to insulin, or could glucose also be playing a role? Obviously glucose passes the blood-brain barrier, gets into the central nervous system as well. It's very important actually for function. So we have to differentiate that. And what we wanted to do here is next perform a hyperinsulinemic euglycemic clamp. And I've already showed you data from that. Basically what you do is you raise plasma insulin and you infuse dextrose or glucose at the same time to maintain glucose constant. And therefore now you only have an increase in insulin without an increase or decrease in glucose. And so this is the setup. Hyperinsulinemic euglycemic clamp in 8 subjects, same measurements, MSNA, ECG, blood pressure. Here's the infusion pumps. Again, you got a constant infusion of insulin. We also have to infuse glucose because if you give insulin, what does it do? It takes glucose out of the plasma, right? It's important for glucose uptake. And if you give too much insulin, you're going to have someone go into hypoglycemic shock. So you give glucose back, and we're trying to keep it constant and take it out of the picture. And that's what we've done. This is just an arterialized hand technique for blood sampling. If you heat up the hand, it allows you to get more of an indication of arterial blood rather than venous blood, and it helps to do that without putting an arterial line in. So basically we've done this. Here's the insulin dose we've used, and then we infuse a variable rate of glucose to maintain blood sugar. And that was dependent on insulin sensitivity, which I'll show you at the last slide I present. And then we also did time control. Someone's laying here for about 2 hours, if not longer, while we're doing these measurements. Maybe they're getting agitated and nerve activity is just going up from that. So let me show you the data. Here's insulin levels, and this is showing you the mixed meal versus the clamp over 120 minutes. The point here is when we did the clamp, we didn't give them more insulin. What we tried to do was match the insulin to the mixed meal. And what we then did is we clamped glucose, which is in yellow here, during the insulin clamp and didn't allow it to go up, whereas during the meal, glucose went up. So we have a condition now where plasma insulin is elevated to postprandial conditions and glucose is not changed. So now we can say this is an effect of insulin. Okay, what did we find in regards to the baroreflex sensitivity? That's shown here. This is sensitivity. 0 is baseline. 30, 60, 90, and 120 minutes following an insulin clamp, which is in yellow, time controls, which is in black. So black doesn't change much, so they didn't have, if you didn't do anything, they didn't get an increase in sympathetic outflow. If you give them insulin and you clamp glucose, we got an increase in baroreflex sensitivity that looked very similar to that following the mixed meal. But importantly, we clamped sugar, so now we could say it's an insulin-mediated effect. So one other thing we were able to do here, and this is the last slide I have in regards to data, and it might take a little bit to explain, but what you're doing when you put insulin in the system, if someone's really insulin sensitive, then they're going to have a lot more glucose uptake. So what that means is you have to give them a lot more glucose, right? If you want to maintain sugar and someone's real insulin sensitive, during a clamp, you give them much more glucose. And so this is what that is. This is a glucose infusion rate. The higher the number, the more insulin sensitive you are, because you need more glucose to maintain your sugar. Okay, this is the change in MSNA burst incidence gain. So this is our baroreflex sensitivity measurement. And what you can see is even though we only had 8 subjects, there's quite a tight relationship here. And basically what this means is, again, if you have a high glucose infusion rate, you're super insulin sensitive, you get a much greater change in your baroreflex sensitivity. You have a low glucose infusion rate, you're not so insulin sensitive, you get a small change in baroreflex sensitivity. So one measurement, the glucose infusion rate, is an index of peripheral insulin sensitivity. The change in the MSNA baroreflex sensitivity, we believe, is an index of central insulin sensitivity. And they're related, such that those with the highest insulin sensitivity get changes in the central insulin sensitivity. So just as a summary for that set of data, elevations in plasma insulin following the mixed meal increased arterial baroreflex sensitivity or gain. The hyperinsulinemic clamp did the same, allowing us to say this is an insulin-mediated effect. And then this effect appeared very dependent on insulin sensitivity. The more insulin sensitive you were, the greater the change in baroreflex sensitivity as well as glucose uptake. So just a take-home message overall from the talk, I showed you initially that insulin through the central nervous system increases sympathetic outflow. We discussed how that's probably a balance because insulin through the nitric oxide system can also cause vasodilation, which is critical for glucose uptake in skeletal muscle. The two of those balance, and that's important to maintain arterial blood pressure. Next, we talked about insulin sensitivity, and an increase in insulin sensitivity appears to increase the ability of insulin in the central nervous system to increase sympathetic outflow. So not only do you have peripheral insulin sensitivity, you also have a central insulin sensitivity. We then discussed the baroreflex and how insulin can have a direct effect on arterial baroreflex control of sympathetic outflow, and that effect being a positive effect where insulin increases baroreflex MSNA sensitivity, which is important, likely following a meal. And then lastly, we indicate that that also is influenced by insulin sensitivity. Subjects who are most insulin sensitive have the greatest change in baroreflex sensitivity or gain. And so just to finish, a couple of acknowledgments for the people who've done most of the work. Actually, both of these projects were Colin Young's dissertation work. The other individuals were assisting. These studies require quite a few people to pull off. John Tifo, he is more of a metabolic guy. I'm more of the autonomic nervous system, but he runs the clamps for us, and he's very familiar with that. So we couldn't do these studies without him. This here is our medical support, 2 physicians and our research nurse, and then our overall grant support. You have to have money to do the studies. And with that, thank you for your time and attention.